Good morning, everyone, and welcome back to the Action Collaborative's virtual symposium. I do hope that you all were able to tune into our very informative keynote session from just earlier this morning. Before we move on with the program for today, I would like to thank the Action Collaborative Steering Committee, our working group co-leads and working group members, all of who have worked together very closely over the last 2 years to produce novel work that advances the field, accelerates action where the evidence dictates, have conducted strategic outreach efforts, and led numerous convenings, webinars, and other special events to accelerate the translation of the most promising opportunities to reverse the opioid crisis. In addition to the Action Collaborative's core priorities and work, we have also taken on a number of special products and activities to elevate how the COVID-19 pandemic has exacerbated the ongoing addiction crisis in the United States, as we have heard from both Dr. Zhao and Ms. Frederique. During these challenging times, the Action Collaborative remains wholly committed to supporting the health and well-being of individuals with opioid use disorder, other substance use disorders, and chronic pain. We believe it is critical to ensure that the health, safety, and care of those with substance use disorders and pain are preserved in the near and longer term. We do encourage you to share the Action Collaborative's COVID-19 products, which include a resource page sharing emerging COVID-19 resources across the Action Collaborative's membership, a statement from our steering committee, which identifies critical priorities and actions for providers, health systems, researchers, policymakers, regulators, and health leaders alike that must be taken to protect individuals with substance use disorders and pain in the context of this pandemic, and a collaborative webinar series with practical tools, resources, and strategies to ensure that patients remain connected with their providers, treatment, and recovery plans during the pandemic. We thank you for helping keep the needs of those with substance use disorders and pain at the forefront during the pandemic. Our program today will be focused on the achievements and future directions across the Action Collaborative's working groups. Through today's symposium, we hope to achieve 3 objectives. First, foster greater awareness of the critical gaps in the opioid crisis response. Second, elevate key opportunities to address those needs and facilitate a more effective and efficient response. And lastly, determine the practical approaches and strategies that can be used for the future. I will now provide an overview of the Action Collaborative's work and then describe our sessions for the day. To date, the Action Collaborative has made an important and unique contribution. It has convened and aligned diverse stakeholders across the health system to catalyze a more coordinated and comprehensive response to the crisis. And this is something that you will see reflected across each session today. The Action Collaborative is collectively addressing 4 high priority elements of the nation's response to the opioid crisis: health professional education, pain management guidelines, prevention, treatment, and recovery services, and research data and metrics needs. These topics are also the focus areas of the Action Collaborative's 4 working groups, who you will hear from today. Over the last 2 years, the 4 working groups have identified key gaps in the response to the crisis and have developed and disseminated solutions designed to reduce opioid misuse and improve outcomes for affected individuals, families, and communities. If we go to the next slide, please. We'll provide an overview of the format for the sessions today. There will be 4 45-minute sessions, which will include working group presentations, a reactor panel, and discussion. And this format will be repeated across all sessions today. Each session will begin with a working group presenting their key updates on progress to date, highlighting findings from their work products, as well as tools and resources created across their broader portfolios. In addition, each working group will present actionable priorities for the future and their plans to implement those priorities. The working group presentations will take approximately 15 minutes across each session. The presentations will then be followed by a reactor panel, which will take approximately 15 minutes to provide input on how the group's work to date can be advanced moving forward. We're delighted to have our reactors with us today. Each reactor panel is incredibly diverse and consists of experts from across the field. Cumulatively, across the panels, we have perspectives represented from regulatory bodies, educational program development, from health systems, payer communities, peer support, persons with lived experience, and research translation organizations. Following the reactor panel feedback, the remaining time in the session will be used for follow-on discussions between the presenters and the panelists. While we will not be holding a formal Q&A with the audience, you may use the Q&A button at the bottom of your screen to share your thoughts and/or questions, and time permitting, we will try to incorporate your input into the sessions. We're very much looking forward to the program today and hope that you will leave with a better understanding of how the Action Collaborative is addressing the national addiction crisis and the impact of this work. With that, I will now introduce the first working group session for the day, which is focused on health professional education and training. Addressing health professional practice has historically not been the center of the response to the crisis, despite the prevalence of persisting gaps across pain management and the treatment of substance use disorders. The education and training work group thus seeks to catalyze change across the health education continuum to promote the uptake of best practices and enhance patient-centered interprofessional care to better meet the needs of health professionals and patients alike. I am so delighted to introduce the session participants for today. The presentation today will be delivered by our Education and Training Working Group co-leads, who are Dr. Kathy Chappell. She is a Senior Vice President of Accreditation, Certification, and Measurement, and the Institute for Credentialing Research and Quality Management at the American Nurses Credentialing Center. And Dr. Eric Holmbo, who is the Chief Research, Milestones Development, and Evaluation Officer at the Accreditation Council for Graduate Medical Education. Dr. Steve Singer, who is the Vice President of Education and Outreach at the Accreditation Council for Continuing Medical Education. And of course, joining our co-leads for the session are our expert panel of reactors, who are Dr. Gordia Bannister, who is the Executive Director of the Institute for Patient Care at Massachusetts General Hospital, Dr. Graham McMahon, who is the President and Chief Executive Officer of the Accreditation Council for Continuing Medical Education, and Dr. Jeanette Tetreault, who is a Professor of Medicine at the Yale School of Medicine and is the founding Program Director for the Yale Addiction Medicine Fellowship and the Associate Director for Education and Training for the program in addiction medicine. Their full biographies are available on the event website for you to access. And now I will turn things over to Dr. Chappell, who will be leading off our presentation.
Thank you, Aisha. And what a great job with all those professional titles and keeping those in place. And to everybody, thank you for joining today. What a fabulous keynote presentation. And as I was listening to that, I was thinking about some of the professional practice gaps that we actually identified in our literature review and our validation survey that will come out, and I think is absolutely reflective of the keynote presenters' perspective. So if you can go to the next slide. On behalf of the Education and Training Work Group, I'm very happy to share the outcomes of our work over the past 2 years. As Aisha said, I co-chair the work group with my colleagues, Eric and Steve. Unfortunately, Eric is unable to join us today, so Steve and I will be teaming up for this presentation. Eric is involved in some very important COVID work. Our mission, as stated here, is to work across or toward a coordinated interprofessional, patient, and family-centered approach for the continuum of health professions education that addresses acute and chronic pain management and substance abuse. And we identified 5 objectives for this past 2 years that we're going to share today. If you go to the next slide. Great. So here's a summary of our key activities. We started off with conducting a literature review to identify and analyze professional practice gaps across 6 health professions: medicine, nursing, to include registered nurses and advanced practice registered nurses, PAs, dentistry, and medicine. And we started that literature review with over 800 articles and ultimately coded and analyzed 310 articles. And what we were looking for were professional practice gaps that related to those 6 professions. And then following that, we conducted a validation survey that was disseminated to both individual clinicians and to organizations of subject matter experts for their input. We wanted to know, is that from our survey, was what we found in the literature accurate, and was there anything that we missed? And I want to call out that we focused on these 6 professions based on their prescribing authority or their close connection to supporting the prescriber and the patient. And pragmatically, we really had to limit the scope of our literature review to something that we could achieve within the time frame of the Action Collaborative. But we absolutely do not believe that these are the only professions or the most important professions who care for patients with substance or pain or substance use disorders. This is truly a limitation of our study. We do believe, though, that the processes that we use to evaluate and code the literature and to conduct our validation study could be replicated across the other professions. Then concurrently with the literature review, we conducted an environmental scan of accrediting, certifying, licensing, and regulatory bodies to explore their requirements and standards as they pertain to both individual clinicians, to programs, or to organizations. And we're now in the midst of pulling all those findings together into a white paper that outlines educational frameworks across the education continuum and across professions, and plan to include exemplars that will help operationalize those frameworks. So if you can go to the next slide. So here are some of our achievements. We were able to summarize the root causes of professional practice gaps and where they fit into the stages of the care process. We were able to report such variables as professions that were the most reported in the literature, the type of practice setting where they were located, the types of pain that were most often treated, and the patient populations that were most prevalent in literature. And the qualitative review that we conducted, because it was a mixed methods assessment, we did the quantitative work, and then we did some depth in terms of a qualitative look at the literature. And that provided more depth to those quantitative findings and provided some themes for further exploration. We also documented the current landscape in relation to pain and substance use requirements by accrediting, licensing, certifying, and regulatory bodies, and identified or were looking for areas of variation. We've almost finished that white paper, and we look forward to expanding on it in the upcoming months and with feedback from the other working groups in the Action Collaborative. Next slide. So I think here are some of the seminal findings from our literature review. Very prominently, prescribing or tapering opioids represents the most challenge for clinicians. And then authors also cited lack of clinical knowledge, attitudes and biases, and lack of access to tools and resources as the most common causes of professional practice gaps. Now, we do know this is based on the peer-reviewed published literature, so that also is a limitation, and that was really the reason for our validation survey. And then other factors included communication challenges with patients, families, or other healthcare team members, and constraints in the practice setting as contributing to professional practice gaps. One area in our validation survey that I think is interesting, particularly in relation to our keynote speaker and into the root cause of attitudes and biases, in our validation survey, we asked people to reflect on their own practice and then ask them to reflect on the practice of others. And when people reported their own practice gaps related to attitudes and biases, they felt that they themselves were not particularly biased in their care, but cited other healthcare providers were biased in their care. And I think that's an area that we would want to dig into in terms of self-reflection and examining individuals' own practice behaviors. So if you can go to the next slide. So expanding on the previous slide, we certainly see opportunities in the following areas, and they include educational interventions that might be targeted to individual healthcare providers and to healthcare teams that are important regardless of the clinical topic area, and that form a foundation for healthcare practitioners to provide high quality, evidence-based, and compassionate care. And there are also educational interventions that might be targeted to individuals and healthcare teams that specifically relate to pain management and substance use disorders, and they're reflected on this slide. And you'll see there are many system level interventions that are going to have to be addressed for this, for any intervention to be successful. If you can go to the next slide. So this is a short overview of the survey findings from the accrediting, certifying, licensing, and regulatory bodies. We found in this snapshot that there was substantial variation across the groups, and there was more variation in requirements that pertain to individual healthcare providers as compared to those that pertain to programs or organizations. And there was also variation that occurred between professions, between specialties within a profession, and in relation to the oversight used by the individual accreditor. We go to the next slide. And finally, there may be some valid reasons for that variation by profession. For example, those who practice under direct supervision of another professional may have different requirements and standards, but I think it's an area for further exploration. Mandatory CE, a tool that is often employed, but likely not effective, and that's an area for further exploration. What strategies are most effective in addressing behavior change? And there certainly exist opportunities to explore how organizations that have a regulatory lever can work together to advance preventing and treating patients with pain and substance use disorders. And with that, I'm going to turn it over to my co-chair, Steve, who will finish the presentation. Thank you.
Thanks, Kathy. It's a pleasure to be joining you today. If we can go to the next slide, please. So just wrapping up the key conclusions from the two studies, we've summarized some major themes here. And then following this slide, I'm going to share with you some key priorities that we've identified. So among the key conclusions is an awareness that we need to better equip healthcare providers with profession-specific competencies. The complexity of both the practice environment and the population of patients that individual professionals and teams serve, as well as the environment of regulatory and other requirements, really brings to focus the need to be able to guide in a more informed way the individual competencies that will best serve clinicians and patients in specific settings. The second point here is understanding that although there is a great deal of effort and consensus about the need for regulatory policies and requirements to support addressing different aspects of the crisis from pain management, substance use, et cetera, there is substantial variation that in some cases may be unwarranted or unproductive. In other cases might be unintended, but that a key output for our study here is to realize and take advantage of the opportunity for regulators and certifying agencies and accreditors to come together and really work collaboratively to harmonize those efforts. the next point is that we understand that there is a very mature ecosystem of educational approaches across professions, across the continuum, but that the nature in which, the way in which those sort of needs and resources are appropriately matched to each other can really be improved in order to better translate education and training into effective care and improvement in practice. And lastly, this last point is a recognition that to a great extent, the tools for changing practice, the tools for resolving professional practice gaps in different professions, in different settings, are very much things that we in the educational community know how to do. But there needs to be a more dramatic and a better supported implementation of those frameworks in order to accelerate the resolution of these gaps that continue to exist. And specifically, particularly looking at the opportunity to really focus on the interprofessional space of interprofessional education, interprofessional collaboration as a key avenue to moving this forward. Next slide, please. So that leaves us with several actionable priorities that we really want to bring to you, the audience, and to our Reactor panel to respond to, because these hopefully will guide kind of what we can do about this and the action part of our action collaborative. So very briefly, the first priority is to recognize that there are some key competencies that all health professionals need to be able to demonstrate with regard to pain management and substance use disorder. And it's important that you understand that this is not sort of a one-size-fits-all approach, but rather a recognition that some key skills with regard to interprofessional collaboration, the ability to recognize and identify one's own professional practice gaps, and to work and be able to refer patients to specialty needs, those sorts of things are things that we could establish as minimum competencies. The second priority is to realize that the process that our work group has taken to look to the literature and validation survey to understand priority practice gaps is a slow boat. You know, that's a slow way to go about this, and that we need to collaborate with the research community and with journal editors and with educators to create more rapid ways of identifying and continuing to propagate priority practice gaps and competencies. The next priority is that accreditors have an opportunity, again, as a mirror to the findings that Kathy shared, to really substantiate interprofessional collaboration in the educational setting across accreditors, from standards, policies, curricula, guidelines, really working together to get this done. Next slide, please. So the, you know, as an extension of the previous, certifying bodies for a great extent, you know, set expectations for their profession. So how we can facilitate for certifying bodies to work collaboratively for both dialogue and a productive work intraprofessionally, interprofessionally, to provide greater support to interprofessional teams and interprofessional practice is essential. The next point, Kathy mentioned continuing education. Continuing education requirements are probably the single greatest lever that regulatory stakeholders are using in order to address professional practice gaps for different health professions. A lot of these organizations are in communities and very tuned into local practice setting specific gaps, but they need greater support. They need both the lowering of regulatory obstacles and other barriers that keep them from being most effective in providing the right education to the right clinicians at the right time for the right patients. This kind of ties into the next point about optimizing regulatory approaches. State licensing authorities are already, as we will hear, going to be meeting as a result of our work with the Action Collaborative. But we want to support that collaboration to find opportunities for them to harmonize the way in which education, accreditation, and other stakeholders can support their work and the needs of the public. The last point here is there are a number of statutory practice improvement initiatives. The keynote speaker mentioned some of them with regard to medication-associated treatment, Medicare, FDA, SAMHSA. All of them have significant practice improvement initiatives that are taking place in different ways, but the degree to which those initiatives are integrated with other aspects of the system, such as continuing education and across the continuum, is an area that could be improved. So that's another priority for us to address. Next slide, please. So taking this forward, we want for the working group to continue to elevate critical gaps, facilitate alignment between these different stakeholders, accrediting, certifying, licensing bodies, and advance the way in which we can share best practices for educational efforts in order to both study those strategies and approaches that work best, and also help to elevate practice in the educational community across different settings. Next slide, please. So the last couple slides here is just talking about proposed focus areas for the future. We want to convene, this is sort of in pursuit of the priorities that I just spoke to, convene expert to address these key competencies, partner with health education institutions and hospital systems, again, to study those projects that are most efficacious, work with accrediting, certifying, and licensing bodies to both reduce unwanted variation and advance the harmonization strategies I spoke to. Next slide, please. And in these commitments, use evidence-informed educational approaches and regulatory requirements that really are very closely tied to not only what we have discovered in our own literature review of practice gaps, but as I mentioned before, sort of an evolving understanding of practice gaps, and being sure that the clinical curricula are aligned with those needs for pain management, substance use disorder treatment. And then lastly, of course, is to continue to develop benchmarks that measure our own effectiveness in doing that as a collaborative, and hopefully also model this process as a way to address other complex public health imperatives and priorities. Okay, so with that, I'm going to hand it back for our reactor panel.
Great, thank you, Dr. Chappell and Dr. Singer. We'll go ahead and begin with our reactor panel feedback, and we'll start with Dr. Bannister.
Good afternoon, or actually good morning, everyone. First of all, I just want to thank you for the opportunity to address such a distinguished group and this incredible work that's underway in terms of trying to address important societal issues. I must say, while you were asking for suggestions, I may have more questions than answers. I thought it was paramount and important that you've positioned or talked about this crisis from a framework that included the socioeconomic status, race, access to care, insurance coverage, and really, as you were looking at this crisis, including the importance of the social determinants of health and structural and systemic issues that need to be a part of the solutions. While this may not be the focus of the health professional education and training group, I did think that there was some attention that needed to be paid not only to the educational interventions, but also to how and who are we going to educate for the next generations of healthcare professionals and their diversity or lack thereof. Many times in this document, there was a discussion about the importance of interprofessional collaborative practice, interprofessional relationships, interprofessional dialogues, interprofessional convenings of different groups. I think it's really important that interprofessional education strategies are not easy. It's important that it requires high functioning collaborative teams that are really engaged in a partnership in order to really address these issues and concerns in a meaningful way. The voices from both the practice and the other sides, whether it's regulatory, credentialing, providers, and others, we all need to either be heard and or listened to, because understanding each other's experiences is critical in order to advance this important work that you've been addressing. While this was briefly mentioned, these recommendations need to be backed up by faculty development and the development, evaluation, and dissemination of interprofessional educational programs, materials, and models that have been shown to be effective, which you referenced. There's already been a lot of work in this area in terms of education. And one of the things I'd like to cite that I learned of is the Center of Excellence in Pain Education. This was a program that was developed by an educational program developed by the NIH that was put on hold last year. And I'm wondering if it's possible in terms of recommendations and suggestions in order to have that funding restored. I must say I was daunted by the statement that the educational system in one of your slides, that you were considering establishing a national tracking of health professionals' achievement of competencies. I really think it is important to understand the depth and breadth and scope of that statement, because I wondered if you were including licensed professionals, if you were thinking about undergraduates and students, or others that were involved in specialty certification. I questioned whether that was feasible, but that may just be my own point of view. There was also a section in the report that described that healthcare providers are struggling to care for their patients. While the report suggests the importance of unleashing the capacity of continuing education for health professionals, how do we expect them to engage in these activities without support, without additional resources, and how is that going to be paid for? And then lastly, again, these are incredible and wonderful recommendations. How do you plan to implement all of these changes that need to be made across so many different professions with their regulatory and accrediting agencies, when all of these groups, and please don't take this disrespectfully, sometimes may be slow to change? Where will the leverage come from to accomplish these goals? And I know Dr. Singer talked about that there was already some groups that were convening right now, so I was very happy and delighted to hear about that. But the question is, who will be taking the lead in regard to this important crisis? Thank you so much for the opportunity.
Thank you so much for your remarks, Dr. Bannister. We're now ready for Dr. McMahon to share his feedback.
Thanks very much, Aisha. Thanks, Gordia, for your comments, and huge thanks and appreciation for the working group's efforts over this last 2 years to produce a remarkable piece of work that outlines so many of the needs of the community for this very complex and enormous problem. It's really clear that we have a responsibility to fix this problem. To some degree, health professionals contributed to this problem. Health professions education contributed to this problem, and we have a responsibility to be part of the solution. To some degree, we are in a terrific situation in that health professionals are remarkably efficient and effective learners. They can change their practice, they can learn new skills, they are motivated for mastery, and they want to do the right thing for their patients. That's an ideal situation for us to be in. But of course, health professions don't exist in a bubble. They are surrounded by a lot of healthcare system chaos. They are pulled in a remarkable array of directions. They're in many cases burned out, and the competing demands on them are simply exhausting. It's also clear, though, from the report and from a lot of evidence that we have about this entire crisis, is that there is a demonstrable confidence competency gap. Most clinicians are relatively complacent and in some degrees ambivalent about their role and responsibility to be part of the solution. Many clinicians and prescribers consider this not my problem, not my responsibility, not my fault, and not in my control. And when all of those factors are present, you are going to have an enormously challenging time moving anybody to a new position of empowerment and responsibility and enablement and new levels of competency to fix this problem. Levels of complacency, and particularly when there's a confidence competency gap, create errors. If people are doing things that they shouldn't be doing and they think they're doing the right thing and get no feedback about it, errors will be perpetuated and nothing will change. And we've seen how difficult it's been to change the entire community over the last few years because of this problem. Having said all that, health professions certainly are remarkable learners. They live in a world of many competing demands, and they are relatively complacent about their role and responsibility for this particular epidemic. It's also true that health professions education works. When you can engage a clinician and when you can teach them and remind them and reinforce what they've learned and help them build skills, we have seen time and time again that it works. They really do change their behavior, they change their practice, and patient outcomes benefit. So what do we do? Certainly education has to be designed away from being information transfer to practice development. We live in a world of information ubiquity, and there are now opportunities to create real change through deliberate practice, feedback, assessment, performance. But from an accreditor perspective, there's got to be carrots and sticks to engage those who would least be likely to think that this is a problem they have to solve. And the way you do that is by aligning regulatory expectations as the report recommends, creating a universal standardized curriculum for maybe low volume prescribers and potentially high volume prescribers, and for those who are learning about substance use disorder, and separating out those issues around pain management, identification, and interventions for substance use disorder. But then there's got to be an assessment and a remediation system. There's a lot of controversy as to whether the ownership of that system should be based on DEA licensing, for example, or should be voluntary, delivered or mandated by the states and in practice licensing, for example, or other areas. But without some sort of a floor of a competency expectation, it's going to be really hard to move those who need to be moved the most. So I think the bottom line is that there's huge opportunity here to make an impact. There is enormous responsibility for us to make an impact. There are real insights here that allow us to carve a path forward. But my worry is that a report like this will get lots of celebration and rounds of applause, but generate absolutely no actual change. And until we specify who needs to do what when, and ensure that all of us are working together to solve this problem, we won't get anywhere. And the leadership of the National Academy is ideal to allow us to be in a position where we can actually drive this process forward together across the professions and fix this problem for the public health and the public well-being. Thank you.
Thank you so much. And our last reactor for the panel is Dr. Tetreault. So I'll hand it over to you and then break into our discussion.
So first off, I want to thank the National Academy of Medicine for inviting me to be a reactor with my esteemed co-reactors and to provide feedback on the excellent presentation by the working group. I really do commend the group for completing a tremendous amount of work and taking a very thoughtful approach to addressing an extremely important topic. My point of view comes from that as a primary care physician and an addiction medicine specialist, as well as an educator who's dedicated to improving health professions education for substance use disorder specifically. I framed my comments around 3 questions that were posed to us as reactors. So the first question was really around, were there any surprises? Well, it's not surprising that lack of knowledge, attitudes and bias, and failure to use evidence-informed tools and resources were the root causes leading to these professional practice gaps. It's nonetheless shocking in the midst of one of the most pressing public health threats of our time. And as has been stated, we have over 130 Americans dying every day from an opioid overdose. And only 1 in 10 people who need treatment actually access it. There's lots of reasons for this, but certainly health professions education is a big part of that. COVID-19 pandemic is only worsening these numbers and leading to further disparities with regard to assessment and treatment access. Similarly, not surprising is the incredible variation between the limited education that does exist across the training spectrum. So how can we still have significant education and practice gaps while this crisis continues to ravage on? And I appreciate the working group's focus on the need not only for educational interventions, but also health system level interventions that can leverage interprofessional teams and allow for easy access to information and resources at the point of care. And of course, these interventions need to be rooted in evidence, as well as integrated with efforts that consistently address stigma and bias, as well as dispel misconceptions about addiction and addiction treatment. So the next question we were asked to consider included potential facilitators and barriers to implementing the proposed actions. Certainly, I think from a facilitator's perspective, the backing from the National Academy, as well as health professions accrediting agencies and health professions organizations, all of whom have a long history of collaboration, will facilitate the ability to implement the proposed actions. And the key will, and this has been brought up by my co-reactors, the key will be how to translate the outcomes of the collaboration into actual action at the academic and community levels. Some of the barriers and cautions that I see, I do worry about conflating education on pain management with education on identification and treatment of substance use disorder. While I agree education in both areas is necessary and some overlap needs to exist, they're not the same and should not be measured with the same tools. Can kind of be thought of as a Venn diagram, with one circle representing acute and chronic pain management and the other representing opioid as well as other substance use disorder. And while there is that overlap in the middle, there's distinct nuances that need to be addressed throughout the educational system outside of that overlap. Additionally, I think the focus should not just be on prevention, management, and treatment, but we also need to empower our learners on how to appropriately screen, identify, and diagnose. And lastly, we cannot lose sight of the patient voice and the patient experience. In treatment, we need to meet patients where they are and respect their autonomy. We heard that time and time again in the keynote address this morning. This needs to be integrated into health professions' educational interventions. Similarly, I think we need to meet learners where they are and be creative with regard to faculty development. This was brought up by another one of my co-reactors in an effort to sustain any UME or GME type interventions that occur. So the last question was about stakeholders and who's needed to implement these strategies. So many stakeholders have been identified and included in the collaboration already. However, especially with the mission to work toward a coordinated, interprofessional, patient and family-centered approach to education, I think individuals with lived experience and families, as well as learners, should be the implementation strategy. Additionally, community health center addiction treatment programs, harm reduction services should be included. Too often, our health professions learners are exposed to patients with opioid and other substance use disorder at times of crisis, rather than when they are doing well in addiction treatment or accessing needed services. So this can be done with the establishment of community advisory boards and strategic academic and community partnerships being enhanced. Lastly, I feel academic leaders need to be included and empowered to recruit and retain faculty who bring diverse voices to the table. These leaders can then empower the faculty in 3 key areas as I see it. They can empower them to break down silos and deliver true interprofessional education, which we know works, so that all learners have the same baseline knowledge, and then develop profession-specific education in an effort to collaborate and build off a common foundation. Can also empower faculty to establish community relationships outside of the academic institution to allow for bi-directional learning and consider mechanisms to deliver evidence-based science into practice in all settings. So there's really no wrong door into the healthcare system in addressing pain or substance use disorder. And lastly, encourage faculty to highlight the importance of competency-based education throughout the educational continuum, rather than just a top-down approach or a contingency-based approach whereby education is linked to licensing or accreditation. The importance of this work needs to be elevated and role modeled across the training spectrum. This can be done by establishing addiction divisions and promoting establishment of fellowships or other advanced training within academic institutions to be the hub in a hub and spoke model of education throughout the community. Thank you very much.
Thank you to all 3 of you who agreed to give us feedback, which is critically important. You know, this is a tough situation. It's a complex system that we're trying to impact through multiple stakeholders. So very much appreciate your feedback and your perspective. I think Steve and I have a couple questions that we'd like to pose to the group.
Sure. So this has been very helpful, and a continuing conversation, I hope. So for Jeanette, Graham, and Gardia, I want to go back to a question, Gardia, that you raised during your comments about leadership. And because so much of what we're talking about is a complex system and multiple practice, multiple health professional kind of focus, I wanted to ask each of you to respond about the way in which institutional learning, you know, we talk about learning healthcare or a culture of learning, and ensuring a place and priority for addressing these issues around this crisis within that institutional framework for quality improvement and learning. I'm interested to hear your thoughts about perhaps the obstacles to that and how we could overcome that, how we could approach that from a leadership perspective. Gardia, why don't we start with you, since you sort of raised this question at the beginning.
So I think it's just very challenging. But what I would recommend, or in my thinking, as I've watched the importance of quality and safety as an example within our organization, and certainly right now in the midst of what's going on with COVID, social unrest, health disparities, and social injustice, we've been able to raise up and say that we need to look at how health equity is equally as important as quality and safety. And so I would recommend that a strategy be that education has to be at an equal level, because at Mass General, as an example, we're always looking at safety and quality metrics constantly. Now we are also looking at health equity metrics. we have to decide that we're going to give the same kind of priority that we give to those other initiatives to education. And then when we do that, and the importance of your report, I think is so, lays it out very well, is how can we link what we're doing with education and help it to frame our clinical outcomes with our patient care. That would be my thinking.
Thank you. Graham?
Yeah, of course, I agree with Gordia. She's right on. I think there are a couple of elements here that are really important. The first is that learning pain management or management of patients with substance use disorder is not a checkbox exercise. The worst thing we can do is tell people to sit in a room for an hour, throw information at them, give them a checkbox and say, now you're done, go and practice correctly. That will not work. And in fact, will probably backfire in meaningful ways. Changing behavior, changing practice requires the organization and the individuals within it to feel some responsibility, be curious about how to do this right, and then learn the skills to be able to do it right. And that requires you to have the organization, in many cases, whether it's a small rural clinic or a large urban academic medical center, to say, we have a responsibility to take this on. Organizations that do that and realize that their employees, their most precious resource, are not infallible, and that they have an opportunity to improve when you invest in them, will benefit hugely. And education is part of the solution for that. Our community can learn, they can change, but there has to be a culture around them that supports that change. They will reward you every time you invest in them. Health professionals are remarkable, and they'll particularly respond when you nurture not only them individually, but them as members of a collaborative team. So all of us have a lot to gain from that type of an investment, both in time and resources in our people, our most precious resource.
Thanks, Graham. Jeanette?
Yeah, thank you. I completely agree on all the comments that have already been made. I'll just add to that I think, again, this idea of checkbox or a one-off course on this, providing adequate instruction and supervision is really wrong. We need to think about threading this throughout healthcare education, right? As well as linking it opportunities for mentorship and real practice mentorship coaching, right? So are there ways that we can, link folks who learn this stuff? We'll use the example of a buprenorphine training. Many people go through the training and never once write a prescription. And that's because they don't have the practical skills or the, clinical oversight to do it. So can we link them up? And there are lots of models where this has worked well. I think using technology and leveraging that, like echo programs and things like that, can also for situations where there aren't a critical mass of potential mentors and coaches. So those would be some practical suggestions building off what my colleagues have mentioned.
Thank you. Thank you. I think I'll take the last question and your perspective. All three of you recommended, kind of a comprehensive interprofessional approach for this to be successful, and recognizing and valuing each team member's contribution, and kind of taking a leadership role and holding each other accountable. So that means the resident says to the nurse, man, that really wasn't a great way that you addressed that patient, or vice versa, that we're holding each other accountable, not only within profession, but across professions. What pragmatic step do you think that our working group could take in terms of leaning into the interprofessional levers that we have to improve collaborative practice and to hold each other accountable in this area? Gardy, you can go. You want to start? I saw you took your comment.
I was gonna wait for my other co-reactors who were fantastic.
Dead silence, crickets.
So my comment is that we must start early. That education, in my perspective, in terms of the different disciplines, Even though things are changing, we are educated in silos.
Mhm.
And until there are more opportunities very early on in our educational pathways for every single discipline to have the opportunity, one, to understand exactly the scope of practice for each discipline, and how do we come together and work as a team to deliver effective clinical care. If we don't start there, I think it is problematic, and we're constantly playing catch up right now. But if it starts early in one's career as a student and they've come together, it's so much easier to be able to give that kind of feedback, or to build on each other's skills and expertise to really care for these very complex patients that we've been referencing today.
Thank you. So Graham.
I kind of slightly disagree with Gordia, actually. And the reason is that we can teach medical students, we can teach residents how to practice in teams, but if they don't see that's how we actually practice, they will conspicuously ignore us every time. And in fact, we will not change the culture. And I find it's often a default position is invest in our students and our residents. And we forget the harder thing of investing in our professionals in practice, because they have to model their behavior to the students and the residents. So I say the investment first has to be in our professional practitioners, so that they can model best behaviors. And that requires a variety of changes in how we teach, how we learn, how we give up some of our traditional autonomy or authority. You know, these traditional hierarchies that used to be around, where the doctor, you know, excuse me for saying this, like tell the nurse what to do kind of thing. You know, we have to sacrifice that for the benefit of collaboration, which is ultimately somewhat less efficient, but much more effective, both for the individual clinician, but most importantly for the patient. And we start by creating activities that we plan together as colleague professionals. We learn to respect the capabilities that each of us have, that they are different and they are complementary, they are not inferior, and that we have opportunities to learn from and with each other in reliable and routine ways that augment our capabilities as a group, not detract from them.
Thanks, Graham. And Jeanette, you got the last 15 seconds.
Okay. Yeah, I'll just take a middle ground between my two co-reactors. I agree with both of them. But one way to do this well is to bring our learners to settings where interprofessional teams work well. And I'll just give an example. In my work at a community methadone treatment program, I cannot do my job without the clinical social worker, the medicating nurse, the patient, their family, and we all are on level playing ground and there's no hierarchy. And so I think exposing, recommending that we expose our trainees to functioning interprofessional teams, especially where we're exposing them to patients doing well and living with substance use disorder and accessing resources, I think can be really powerful.
Thank you. Thank you so much to really expanding the discussion and contributing to a better understanding. And we appreciate all of your feedback today. With that, pass it back over to Aisha, I think.
Great, thank you. I'll just echo Dr. Chappell's comments. What a truly thoughtful and engaging session. So thank you all so much. We really appreciate your participation today. With that, we'll take a very short break. We'll return with session 2 at 11:15 Eastern. Thanks, everyone.